Hi folks, it's Amit Pawa here, and thank you for joining me for Best Blocks for the Breast. This is the talk I gave at the ESRA 2025 meeting this year in Oslo, Norway. I do have the standard disclosures I have before every talk, and I do want to highlight some resources. And if you look at our new website, blockitlikei'shot.com, we have an episode just on regional anaesthesia for breast surgery. I would strongly urge you to check that out, and that QR code will take you straight to our new website. Now, when we're looking at the tips and tricks session guidance, and this was a tips and tricks session I was talking in, they basically said, give focused tips and tricks for daily routine clinical practice, be practical and concise, and sometimes I struggle with that, but also teach simple but important secrets on the topic. And I think I'm well positioned to do that. However, there is one problem, and that problem is basically pretty much every year at ESRA I've talked a lot about breast surgery and regional anaesthesia for breast surgery. So how do I keep this interesting? Because ultimately I want to encourage others to do these blocks, and one of the ways I might keep you interested is by being a little bit controversial and saying things I've always kind of wanted to say but haven't yet had the guts to say. So let's start off with that first controversial statement. Patients having breast surgery don't need nerve blocks. This is a comment I heard from some of the surgeons I first started working with when I started doing regional anaesthesia, and this AI model is trying to capture what some such conversation may have looked like. I've also heard surgeons saying the nerves are cut so it doesn't hurt, don't worry, I can put the local anaesthetic in instead of you, and we haven't got enough time for you to do your blocks. So this isn't ideal, and I would ask you, how can we change this practice? So actually the surgeons are saying, I think this patient would really benefit from having a block, much like this AI conversation over here. I think the first thing is work collaboratively with your surgeons and patients. This is shared decision making, so it's not just what we want to do, not just what the patient wants or what the surgeon wants. We talk collectively, and that's really important. There's no point in sticking a needle in the area unless you understand the anatomy of the area, and I'm going to go through that. We've also got to understand the spectrum of surgery. Not all breast surgery is equal, not all breast surgery hurts the same, and also when you're considering these regional anaesthetic techniques, you've got to be sensible and safe. So let's start off with the first bit, working collaboratively and making shared decision making. Now clearly, there are many reasons why we might want to block the breast, and some of those reasons may be more relevant to your particular patient that's sitting in front of you. I think it's important to discuss with both the surgeon and the patient that these are the reasons why you might want to consider regional anaesthesia, and then you can make a joint decision. We've also got to understand the anatomy of the area, and that's where it gets a little bit more interesting. You may remember some of these diagrams from some of my previous talks. We can think about it in terms of dermatomes, we can think about it in terms of terminal nerves, we can think about it about the territories that those terminal nerves supply. So it's important that you have some kind of framework upon which you're going to make your next set of decisions. The next thing you've got to think about is, where is the surgery happening? Is it happening in the lateral breast, is it happening in the medial breast, or is it in fact involving the whole breast and having a mastectomy, for example? And then you want to know, is the axilla involved? Because as you'll see from that diagram in the top left, if the axilla is involved, there are a few other nerves that we need to think about. It's then not just about where the lump is or where the surgery is. We've got to think about where the incision is, because sometimes the surgeons will make an incision directly over the lump. Otherwise, they might try to think about more oncoplastic approaches and be slightly further away, and maybe over the lateral breast, the medial breast, or in fact the whole breast, so covering all of those territories. And then you need to think about whether the muscle is involved. If pec major or pec minor are involved, it may mean you need to think about making sure you block those pectoral nerves, which may not be relevant if they're not going deep down or lifting the muscle up. And then of course you've got to think about the pain trajectory. A simple fibroadenoma, which takes about 10 minutes to operate on, a very small incision, is unlikely to hurt to the same degree as somebody having a mastectomy. And that brings us on nicely onto that spectrum of surgery. If you have a look, there's one side, the symptomatic or the non-cancer surgery, right the way through to the oncological and the oncoplastic, plus or minus the sentinel node biopsy, or the axillary node dissection, which has a different pain trajectory. And each of these different operations has got varying analgesic requirements and pain trajectories, but for the purpose of this talk, I'm going to be focusing on just these areas over here, because I think that's a little bit more controllable. So how do we become sensible and safe when considering the regional anaesthesia options? I think it comes down to sticking to some sensible general block principles, or as I've called them in the past, PowerPoints. So the first one is, think about the technique you're doing and what block gives the best analgesia or anaesthesia. Now, when you think about that block, does the risk-benefit ratio for that block favour being used in this particular situation? So if you're doing a small fibroadenoma, which has a small pain trajectory, can you justify the risk of doing a paravertebral in that indication? I would say probably not. You then got to think about patient factors, whether they've got favourable or unfavourable anatomy for the block you're thinking, whether that anticoagulation profile is something that would make you caution whether to do the procedure or not. Have they got infection? What's their pain like? What are the respiratory issues like? Are there factors that may make you more likely to do a block? Do they have an opioid use disorder and you think, aha, I want to do whatever I can to reduce the pain? Of course, then you've got to think about anaesthetist and surgeon factors. Do you, as the anaesthetist or the anaesthetist who's doing the procedure, have the skill to do the block that you think will give the best procedure? Are you happy doing it? Are you comfortable doing it? Is the surgeon happy for you to do it? And lastly, what happens if you don't do anything? You know what the best block is. What happens if you don't do anything? And are there any other alternative strategies other than your plan A? If you use that footprint, that will help you out. So now let's focus on the breast. And we're going to take a bit of a walk through thoracic park because it can be a bit confusing. Now, I have actually simplified a whole host of the different blocks that have been described to cover the chest. And if you look at that QR code, that will take you to the nomenclature paper, which helped us to simplify some of those techniques. And if you look at each of those techniques, you can see that star indicates where you might perform each given technique. And you see, again, there's quite a few choices here. Now, with that in mind, here comes the controversial bit. So I've shown you a whole host of blocks, and there are many more. But I think, actually, that we only need 3 blocks for breast surgery. I think we need 1 posterior approach, and I think we need 2 anterior approaches. And that's I do think it's slightly controversial to come out and say that. Let's look at the posterior approaches. Well, what technique do I think you should know for the back? Well, it won't surprise you. I think if you can, perform a paravertebral block. And these 2 QR codes will take you to my latest videos, the transverse and the paramedian sagittal approach, the paravertebral block. So if you can do it, paravertebral block, that will get you out of a whole host of trouble. Now, if you can't do a paravertebral block, I think actually the block you need to know is the intertransverse process block. And I will redo a video, but this QR code in the center will take you to a video about how to perform that. So 1 posterior approach, ideally paravertebral. If you can't do that, learn the intertransverse process block. If we're talking about blocks at the front, we've got 2 anterior approaches. I think you need the serratus anterior plane block, and this QR code will take you there, or the parasternal, or rather and the parasternal intercostal plane block. The serratus anterior plane block will get the anterolateral branches of the intercostal nerves, and the parasternal intercostal plane block will get the anteromedial branches of the intercostal nerves, and those QR codes will take you to those new videos. The only time I would consider doing an interpectoral plane is if the patient was going to be having an axillary node dissection. I would add that in as a separate injection, or if they were having subpectoral implants, which we very rarely do now. So I know what you're thinking. Why did I say if you can't do paravertebral, think about the intertransverse process block as opposed to anything else? And the reason is it comes down to this. So we have said for years, when you understand the anatomy of the paravertebral region, you've got your transverse processes, you've got the ribs and the costotransverse junction, and then you have got this structure here, the superior costotransverse ligament, which acts as the gateway to the paravertebral space. We said your needle had to definitely be the other side of that, so ventral to that superior costotransverse ligament to get a good working paravertebral block. But of late, a lot of interest has now focused on this retro-superior costotransverse ligament space. And why is that? Well, there have been a number of papers, and we first started talking about it when we described the MTP block, which we've now called the ITP block. And then there's been this really lovely paper which I want to focus on here. And this paper, they did a micro CT of 11 cadavers, and what they were able to elucidate was actually when they looked at the anatomy of this region, there were medial and lateral slits either side of this superior costotransverse ligament that essentially could act as a conduit for local anesthetic and drugs to move between them. So we now know that rather than being a thick sheet that's impenetrable, the superior costotransverse ligament forms an incomplete boundary, and behind that you've got the retro-superior costotransverse ligament space, and that communicates with the paravertebral space by these slits ventrally, but also dorsally with the erectus spinae plane. Now, again, why did I say, well, let's do an ITP block and not an ESP block if you can't do a paravertebral? The problem with the ESP is that many people don't inject deep to the erectus spinae muscle fascia. So you get this lovely sort of spread that's a bit intramuscular there. You can see the lamination of the muscles there, but actually that's treating the ES block a bit like a rectus sheath block, because local anesthetic is not actually crossing deep or ventral to the transverse processes. So if you're not happy to form a paravertebral block, why not do an ESP block but advance just a little bit further and turn it into an ITP block? So this is what's involved: aim between the transverse processes, pierce the erectus spinae muscle fascia, advance into this retro-superior costotransverse ligament space, and if you're going to do a single level injection, inject 20 cc's there. If you're going to do it over multiple levels to increase your chance of getting decent spread, inject 5 to 10 mils per space. So that's what it looks like in a schematic that I've made, but what might that look like in real life? Well, here you go. The needle's gone between the two transverse processes, I've pierced that fascia, and now look, as well as getting some spread anterior or ventral, we're also lifting up the erectus spinae muscle up dorsally as well. So once you've now got your nice, you've crossed that space between two transverse processes, you can aim just to go between. And look, that needle's not going anywhere near the pleura. It's a safe technique, so you don't have to panic about doing a paravertebral. But because you've deposited your local anesthetic closer to the paravertebral space, you're much more likely to have an effective block. Now, this is not just me thinking about it. This study over here that the QR code will take you to, this was performed in patients where they had an interventional CT scan to localize a lesion before having their definitive surgery. They had 45 patients. They all had a single level intertransverse process block with either 0.3, 0.4, 0.5 mils per kilogram. And when they analyzed the spread that they could see on the CT scan, the vast majority of patients did in fact get a paravertebral block with this technique. Not surprisingly, you saw that dorsal spread. You also got an ESP block, but you also blocked the sympathetic ganglion, and actually there wasn't really any difference in terms of increase the number of mils per kilo they gave. So there was no real volume effect on increasing the likelihood. So this confirms to me that what we see in a cadaver and what we see in real life, putting a needle deep to the erectus spinae muscle fascia, actually it does get local anesthetic into the paravertebral space. So I would say that less experienced hands, the ITP is a reasonable substitute for a paravertebral. So now we have all of our knowledge. We are now ready to get on to perform the block. So when should we be performing each block, and are there any tips that we can take on board? So I think let's start off by thinking about the location of surgery. So again, just a reminder, these are those general block principles or PowerPoints. So let's start off with a wide local excision plus or minus a mammoplasty, i.e. moving some tissue and some skin around to make the final aesthetic result more favourable. So probably for a technique like that, the paravertebral block would give you the best analgesia. But you can't always justify the risk-benefit ratio of that. And, it may be that you want to consider patient factors that make you more likely to do a paravertebral block, whether you've got a staff skill mix in order to do that. But what are the alternatives? Well, you could just get the surgeons to put in local anaesthetic, and in a large number of cases that will probably be sufficient in addition to multimodal analgesia. Or you could do location dependent blocks. If it's a medial incision, or there's going to be some pain or discomfort from the medial part from the anterior cutaneous branches of the intercostal nerves, then certainly a parasternal intercostal plane block, either the superficial or the deep variant, is relevant here. If there's a lateral incision, or in fact both, then you could also include the serratus anterior plane blocks here. But you could also do an ITP block, which would be one way of doing a paravertebral without exposing them to the risks. What about a mastectomy? So there's probably no doubt that the paravertebral block is going to give you the best analgesia, and in most situations it's likely to be beneficial. If you look at the risk-benefit ratio, it would be on the benefit side for performing this block for this indication. But again, you want to consider some patient factors. Is the patient of a certain size that may make it difficult to insert? Are there any, is there metalwork in the way? Are there any coagulation issues one needs to consider? So a few things to think about. Again, also staff and skill mix, and what are the alternatives? Well, if you can't do a paravertebral block for one of the reasons above, you could consider doing an ITP block, or again, adding in the chest wall block. So kind of breaking down a paravertebral into its component parts and adding in those location dependent blocks. Or worst case scenario, though I would argue it's probably not that effective, you could use local anesthetic infiltration, unless the surgeon's going to do location based blocks, and they would do interpectoral plane and serratus plane under direct vision. The only other thing I wanted to touch on in this area is axillary node dissection, because if I've ever omitted a PEX block or interpectoral plane and pectus serratus plane block when I'm doing axillary node dissection, that is the one area where the patient complains of pain. And so I think adding in interpectoral and pectus serratus plane blocks for this indication is worthwhile. It's relatively low risk. Again, one might want to consider patient factors. Have they got a pacemaker there, for example? Will that make it slightly more challenging? We have to accept that sometimes surgeons may not like this block, and that's because it makes the axilla look a little bit edematous. They do fear it stops them from being able to use electrocautery or with a bovie to stimulate the long thoracic or thoracodorsal nerve, but actually that's not true, because I've got video footage of local anesthetic bathing the nerves and they can still stimulate it with direct stimulation. But there are alternatives, and you could consider doing a T1, T2 paravertebral block, or doing the deep variation of the serratus anterior plane block, which may not interfere to the same degree as a pectus serratus. But last case scenario, you could consider local infiltration, but it's never quite the same. So one of the other options is, once they've completed the block or the surgery, and they put the drain in, they close the skin, get them to put some local anesthetic via the drain and clamp the drain in the axilla for a while, and that may be one way of numbing that area. Okay, so we know the blocks, we know when we might consider doing what block and when. What about tips for success? So tip 1 is prepare, prepare, prepare. And that involves knowing your anatomy, watching videos of which one of those things you're doing now, but also prepare the patient for what you're about to do to them. Make sure they are fully consented and aware of the process. Prepare your medications, your emergency drugs, the local anesthetics, and the sedatives if you're using those, so that everything you do is nice and streamlined. Make sure that you have IV access, and please don't be lazy. Do apply monitoring, because if you're not careful mid-procedure, you may have an event like this taking place where a patient collapses or faints. It's not unusual for this to happen, especially in the sitting position. Tip number 2 is based upon ergonomics and positioning. Decide what position you're going to use and optimize your room to make that the biggest chance of success. So I used to have the patient sitting, but more often than not now, I'll get the patients in the prone position. Always make sure I put a pillow under the chest to try and increase the thoracic kyphosis. I don't want a lordosis there. And then I plan what I'm going to do in advance. I get the bed and the machine at the optimal height, and I make sure everything is in my line of sight, because everything you want to do is to make sure you have the maximum success and you don't fatigue. The next thing to think about is to make sure when you're performing paravertebral or intertransverse process plane block that you choose the correct level, and 9 times out of 10 for breast it's going to be between T2 and T4. I do have a video on counting ribs with ultrasound. This is a slightly sped up version, but the principle is slide up on the ribs until the most cephalad rib, then come towards the midline, because there you will often see rib 1 hiding. Then mark your ribs out before you do the procedure so you know exactly where you're going to be doing your block, or you could do this in real time as long as you prep thoroughly. The other thing is to make sure, tip number 4 is that you pick the correct probe for the patient. So for the majority of our patients, we can use a linear probe, and that's just fine. But don't be scared of using the curved array probe, especially if the patient has a body mass index sort of greater than 40. In some of those patients living with obesity, you just need to have that slightly better penetration, and it'd be a shame to get a suboptimal view just because of fear of changing the probe. The next tips relate all to needling and being sensible with needling. So this I've talked about before. If you're inserting your needle very close to the probe and the target you've got is some way down, you might find that you struggle to see that needle because the needle is not hitting the beam at an appropriate angle to get the beams reflected back. So sometimes if you insert your needle a little bit further away, it allows you to get a slightly shallower angle towards your target, and it's easier to visualize the needle. The other thing that I see people do a lot without realizing, and it's often because they haven't worked out what right angle to use, is when they're doing a paravertebral block, they end up driving the needle under the transverse process, so then you don't see what's happening at the business end of the needle. This is a slightly dark block, but you'll see the process here. The needle is, has dived underneath the transverse process, so actually we can't see what's happening at all, and I'd be very reluctant to advise this individual to keep moving the needle because I've got no idea what's happening with that needle. Look, the needle's literally underneath the shadow of that transverse process, and I'm feeling very nervous about this whole process. Don't know what's going on here. So if that happens to you, pull the needle back. So we can see here the needle's like, it's about, we're making good progress here. It's about to cross the superior costotransverse ligament. We think we're there, but actually in this particular circumstance, we've sort of seen a drop, but I don't know what's going on. So I've asked them to pull the needle back and re-angle, and now you can see the needle tip clearly in the space. You can see the pleura dropping, so pull back and readjust. If you're using an out plane or in plane, use the wet needle hydrolocation technique, because you see on the image on the left here, actually what we're really doing is bringing the needle in out plane and hoping that we can see where the needle tip is before it's too late. In reality, what you see is on the right hand side, the black and white image, a white dot which we hope is the needle tip, but maybe the shaft, and we've got no idea where we are unless we inject a little lake of local anaesthetic, and then we can see the pleura drop just at that right point. So we call this the wet needle, and Jeff Gazan helped me come up with that idea. That's something he called it, so I've started using it. If you're using a Sika solution, it preserves the volume of local anaesthetic that you really want to administer, and also if your Sika solution contains a epinephrine, it will help you detect an intravenous injection ahead of time. This is an example of using a wet needle hydrolocation for in-plane technique. So the first image on the left, you can see this is a transverse in-plane approach to paravertebral. The needle's there at probably the ESP plane. Now we're going to advance in towards the intertransverse process plane. Still not really getting a great view, but getting an idea. Where's the needle? Is it there? A bit more local anaesthetic coming in. Still not quite in the right place. Advancing a little bit further. There's the needle tip. Boom. There is that pleura drop. So that's another example. And here on the right, not got a great image here, but we can just see the needle approaching. I think that's the needle tip. The pleura's there. It's not quite moved out of the way. Little squidge of local, not quite there. Advance a little bit more. Ooh, and there is that lovely drop of the pleura. So using that wet needle really helps. The other thing I want to talk about is when you're doing fascial plane blocks is consider this intentional overshoot. So go too deep and then withdraw into the plane. And when you're trying to peel open two fascial planes, that's often a relatively reliable way of spotting it. And you get this bidirectional double V sign where you see local anaesthetic injecting in front and behind the needle. If you are going to overshoot into a plane too low, make sure you take care not to go into deeper structures like pleura or blood vessels. But it's an interesting concept, certainly with muscles, to overshoot into the muscle and then pull back into the correct plane, injecting as you go to open up that space. So let's have a look at that in practice here. So here, this is an interpectoral plane. I think I'm in the right place. We've got a needle enhancement software on here. I think I'm in the right place. Oh yeah, I thought that's right. But actually, no, let's pull back because we may have overshot here. And as we pull back, we're going to see if we can get into that space. Aha! Now we can see both fascias opening up. Actually, as advanced the needle, you're getting a much more ventral and dorsal, anterior and posterior movement of local anaesthetic. So that's one way of ensuring that you get into the right plane. So, what are my take-home messages? Well, they are that blocks do have a role in breast surgery, but are not always indicated. If you can, and it's indicated, I think it makes sense to do a paravertebral block. If you can't, perform an intertransverse process plane block because I think that's the next best. Don't forget the anterior approaches. Work collaboratively with your surgeons and with your patients, and make sure you know the anatomy, the pain trajectory and the spectrum of surgery and the surgical site, and personalize your strategy to the patient, ensuring that you use multimodal analgesia as well. have one posterior approach, be that paravertebral or an ITP, and the two anterior approaches, so serratus plane and parasternal intercostal plane. And if you can't perform paravertebral, start with an ITP. Keejin, we were talking initially about starting with ESP, then progressing to ITP, and then paravertebral blocks. But actually, having spoke to Keejin, one of the things he does to make sure his ESPs work well is to intentionally overshoot. So actually, I think for breast surgery, the skill progression should be getting comfortable doing an ITP block, and then when you got the skills, advancing to a paravertebral. Thank you very much. I hope you've enjoyed listening to this talk, and don't forget you can check us out at www.blockitlikeitshot.com for all the latest regional anaesthesia chat. Many thanks.